Thank you very much, Prof. Namal, for the introduction. So I'm going to update on, give you an update on the management of hyperlipidemia. Before that, I have to make an announcement. We hear that a lot of people have joined our online program, and then if there are any more to watch this program, you can watch it through Facebook live as well. So just to let others know, so if they want to watch, they can use it on watch it on Facebook Live. I'm Professor Chamila Mettananda. I'm a specialist in internal medicine, and I'm professor in pharmacology, University of California. So I'm going to talk on hyperlipidemia. I know everybody of you is very familiar with hyperlipidemia. That is something that you encounter every day in your practice. The problem is the guidelines are changing frequently, and to keep up with that is important. So we have 3 latest guidelines. In 2018, we have an American Heart Association guideline, and then 2019, the European one, and the latest one is 2020 NICE guideline. So what I'm going to do is I'm going to take you through the management of hyperlipidemia in a what every doctor should know about, not about very tiny detail. So what's the problem with hyperlipidemia? So we know 80% of our deaths, Sri Lankan deaths, are due to non-communicable diseases. And of those 80%, the commonest cause of in-hospital death is due to coronary heart disease. It accounts to about 22%. So that's a very big amount. And if you take the coronary heart disease risk reduction, that is actually proportionate to the LDL cholesterol reduction. So if you say, if you reduce LDL cholesterol level by 1 millimole per liter, that reduces major cardiovascular events by about 20 to 25%, which is a significant achievement. Therefore, treating hyperlipidemia is very important. Now, who should we treat is the next question. This is very simple. There are only 4 main groups that we need to treat. So the first group is for secondary prevention of cardiovascular diseases. If somebody has developed a cardiovascular event in the past, to prevent him getting a second episode, we give hyperlipidemia treatment, that is secondary prevention. And the other 3 indications are for primary prevention. So what are those 3? So if somebody has very high cholesterol levels, so the LDL cholesterol more than 190, that person need to be treated. Or if somebody has got a 10-year cardiovascular risk of more than 20%, irrespective of their cholesterol level, like if it is LDL within 70 to 100, even if they have a normal LDL level between 70 to 189, still we are going to treat. And then diabetics with high risk, again, need to be treated. And apart from that, there are a few other special groups that we need to know about. Now, next question is how to treat. That's again very simple, only 4 measures. So first thing is we need to exclude secondary causes. And the second thing, we have to calculate their cardiovascular risk. And we provide them with lifestyle advice. And later on, as the 4th step, we start them on suitable pharmacological treatment following a discussion with the patient. So if we discuss about these 4 steps one by one, right? So the first thing, we need to assess the patient. we need to exclude secondary causes of hyperlipidemia. So that can be done by history, examination, and investigation. So history, it's important to ask about previous cardiovascular diseases. They are smoking, alcohol, like other risk factors, but secondary causes of hyperlipidemia like diabetes and hypothyroidism, and also about contraindications for especially statins, like so whether they are pregnant, whether there was a past, it's not really a contraindication, but to be on safe side, just we need to ask whether there was a history of myositis before, or whether they have had any problems with statins before. And examination-wise, blood pressure measurement and BMI measurement is important. And investigations, we have to do a fasting blood sugar or HbA1c level to stratify them. And it is recommended to do a baseline liver transaminases level to have a baseline, so that if there is a ALT rise in future, to like for it not to like mistakenly taken for as statins, or because like if the baseline is also high, then that need be addressed before starting statins. And then we can do TSH to exclude hypothyroidism, and renal functions baseline again is important. And I want to stress and tell you, baseline CPK monitoring as a regular practice is not needed. However, if somebody do complain of muscle symptoms, myositis-like symptoms, then doing a CPK before starting statins is good. Next, we come to calculation of total cardiovascular risk. So as Professor Namal mentioned, so for Sri Lankan, the most acceptable one is the WHO risk score, developed for Southeast Asia region, which was updated in 2019. So we use that risk charts and calculate their risk. And if their risk is more than 20%, you take it as high risk. But depending on the guideline, the risk stratification tool is different. Like if you take the HA guideline, they use the ACVD score, and the European one use the score charts. But for us, it is the WHO risk score. Now, third thing is providing lifestyle advice that everybody knows. We have to advise them on a healthy diet with less saturated fat. We have to ask them to reduce weight to achieve a BMI less than 23. And they need to have exercise, minimum of 150 minutes per week of aerobic exercise. And they should stop smoking. And in Sri Lanka, and according to the NCD ministry as well, so like the best is to advise to stop alcohol, because if we ask them to moderate alcohol, that's not going to work. Now, the fourth thing is pharmacological management. So in pharmacological management, the most important thing I want to highlight is for any hyperlipidemia, any type of hyperlipidemia, the first line treatment is a statin. And our aim is to bring down the LDL cholesterol to the goal. Now, what statin to use is the next question, right? So there again, there are two important things we need to take into mind. One is the clinical benefit of statin is largely a class effect. So whether it is atorvastatin or whether it is rosuvastatin that you are using does not make a huge difference. And the second thing is we need to know the absolute risk reduction using statin is proportionate to the absolute baseline risk. So that means like if you give atorvastatin to a high risk patient, the benefit you get is more compared to you giving atorvastatin to a low risk person. So considering those, so if you decide to give a statin to somebody, then you should use a high intensity, low cost statin. So what do you mean by high intensity? High intensity means like a statin that can bring down cholesterol level from baseline to 40 to 50%. So examples for high intensity statin that is available and in use in Sri Lanka, like atorvastatin, anything about 20 milligrams daily dose, or rosuvastatin about 10 milligram daily dose. This is an important slide. So this shows the statin recommendation for main indication. If you, first, if we concentrate on secondary prevention of cardiovascular diseases. So if somebody has had one previous atherosclerotic cardiovascular disease, the indication is to give them high intensity statin, either atorvastatin 40, or if you are giving rosuvastatin, it is 20. That is the recommendation. The goal is to achieve 50% reduction of the LDL cholesterol from the baseline and LDL cholesterol less than 7. But if somebody develops multiple cardiovascular events while being on high intensity statin, then the goal is to bring down the LDL cholesterol less than 55. That's about secondary prevention. Now, talking about primary prevention, again, for the primary prevention also, we treat only the high-risk people, and so the recommendation is again to give high-intensity statin. Here, the dose is different to the secondary prevention. So secondary prevention, we give atorvastatin 40 and 20 as the base, the starting dose. For primary prevention, we start atorvastatin either 20 or rosuvastatin 10. Again, the goal is the same because we treat only high-risk patients. For them, the goal is to reduce LDL cholesterol level by 50% and from the baseline and the LDL level of less than 40. But then when we talk about, so this primary prevention, this all three groups, the LDL more than 190 patients, or if they have a high risk of more than 20, or if diabetic patients with high risk, in the sense if they do have lot of multiple risk factors, or if their cardiovascular risk is more than 20%, or if they have long duration diabetes, that's type 1 diabetes for more than 20 years and type 2 diabetes for more than 10 years, we consider them as high risk diabetic patients. They should be on high intensity statin. But AHA guideline recommends all diabetic patients to be started on moderate intensity statin. That's slightly different to the practice. Now, that is about the main indication. So secondary prevention, we treat with high intensity statins. Again, for primary prevention of high risk people, we give high intensity statin. Now, talking about special situations, age is a special situation because now all the recommendations that I spoke to you about before are for 40 to 75-year-olds. That is because all the randomized trials and the evidence is for those age group. But beyond 75, now there is data coming in. So there is evidence that it is beneficial. So you may treat a 75-year-old, somebody over 75-year-old, if they are at high risk. But you need to have a risk discussion with the patient, whether the patient actually want to have it, because like you have to consider their cardiovascular risk. They may be on a lot of medications that can give rise to a lot of drug interactions, and their life expectancy, everything has to be considered. And if you decide to start a statin in an elderly person, the best is to start with a low dose, and then you have to titrate it up slowly, avoiding drug interactions. Then what about young age group, 20 to 39 years? Again, there may be a benefit, but there is lack of randomized controlled trials. That is why it has not come directly to the guidelines. But here what we need to do is like we need to calculate their lifetime risk, not the 10-year cardiovascular risk. Because they are young, we have to calculate their lifetime risk. And then we may consider giving statins if they have a family history of premature cardiovascular diseases and if the LDL cholesterol is more than 160. Now, what about chronic kidney disease? So chronic kidney disease, again, like the recommendation is start atorvastatin. The starting dose is 20, but you can increase it depending on the need. But if you think of increasing the dose in a person with the eGFR less than 30, it's better to get agreement with the nephrologist. Then if we talk about CKD patients who are being dialyzed, so if somebody was on a statin, continuing that is okay, but the guidelines does not recommend to initiate statin de novo in a patient who is being dialyzed. Then transplanted kidney. So if they are eligible for a lipid-lowering medication, then statin is the first line. Now, talking about hypertriglyceridemia. So this is the triglyceride level is more than 175 to 500. So like above 150 to 175. Different guidelines again take the baseline lower value differently. But we'll say somebody has a triglyceride level between 175 to 500. And if they do not have a high cardiovascular risk, then the treatment is treating the secondary cause for that and then lifestyle modification. There is no recommendation for pharmacological management for this level of triglyceride unless they have a high cardiovascular risk. But if the triglyceride level is more than 500 and if they have a high cardiovascular risk, then the first line is a statin. That I want to emphasize because like some people with different teaching, they start patients on fenofibrate, but that is not the guideline. So things have changed. So even for hypertriglyceridemia, the first line treatment is statin. So somebody with a triglyceride level of 500 and with high cardiovascular risk, despite being on statin, then the add-on therapy is omega-3 fatty acid. So first line is statin, you add a omega-3 fatty acid. We'll say that the patient's LDL level came into goal, but the triglyceride is slightly high. Triglyceride level is more than 200. Then there is an option to add fenofibrate to a statin. So I think this is something important that we need to get into the practice everywhere. So just starting fenofibrate on a patient with hypertriglyceridemia is discouraged. We have to start the statin. If not controlled, you can add an omega-3 fatty acid. And like if the LDL is controlled and the triglyceride is high, then you add a fenofibrate to statin. I hope I'm clear. Right. So next important is how to follow up. So it's again easy. So our goal is to achieve LDL cholesterol of LDL cholesterol goal. But nowadays, non-HDL cholesterol is also available on the lipid profile. So usually LDL cholesterol plus 30 is the goal for the non-HDL cholesterol. We recommend to repeat lipid profile between 4 to 12 weeks after starting a statin or increasing the dose. That's the guideline recommendation. And statin dose should be titrated up to the maximum tolerated dose to reach treatment goals. Just starting statin would not help. Once the target is achieved, you can repeat the lipid profiles either between 3 to 12 monthly, depending on the availability of the facility. And again, I would like to stress, you do liver transaminase levels and CPK only if a patient is symptomatic. Routine follow-up ALT and CPK is not recommended. So with the economic crisis, we have to be very careful not to overburden labs. So this is the guideline recommendation. So unless the patients have symptoms of nausea, vomiting, icterus, or muscle symptoms, there is no need to repeat this. And when do we stop statin? That's also important. Statin will be discontinued only in a symptomatic patient if the ALT rise is more than 3 times the upper limit of normal, or if the CPK rise is more than 10 times the upper limit of normal. Because you don't do these investigations in asymptomatic patients, so this symptomatic bit is not even needed. So like you do it only if they are symptomatic, and if you see the ALT more than 3 times rise or the CPK more than 10 times rise, then you have to stop the statin. Now, so next important question is, when LDL is not controlled to the target, what can we do? So you have to titrate the statin dose to the maximum tolerated dose and try to bring it down to the target. If that is not being achieved, then you go for second line and third line drugs. The second line drug is ezetimibe in the guideline, and the third line drug is PCSK9 inhibitors, though these are not available for us. These are not freely available. Now, I want to stress again, there is no place for combination of a bile acid sequestrant, fibrate, nicotinic acid, or omega-3 fatty acid with a statin. There is no recommendation. So NICE specifics, I have quoted it directly from NICE guidelines. It says there is no evidence that omega-3 fatty acid compounds help to prevent cardiovascular disease. So this is important. Again, with the economic crisis, don't waste money on unnecessary medication. Right. What if somebody is intolerant to statin? What should we do? Now, we can stop the statin and try and restart it once the symptoms resolve. That's one option. Failing that, the other option is you can reduce the dose within the same intensity group. So like we'll say somebody was on atorvastatin 40, that is high intensity statin, you reduce it to atorvastatin 20, it is still in the high intensity group. If that is also not working, you can change the statin dose to a lower intensity group. So if somebody was on atorvastatin 20, that is high intensity, you bring it down to moderate intensity group. So that's by reducing the statin to 10 milligrams, atorvastatin to 10. Now, failing all those, the next option is to go for ezetimibe monotherapy. Then talking about adverse effects of statins, I would like to stress this. Statins are a remarkably safe group of drugs. But there are side effects, but rare. So if we talk about the muscle-related side effects of statins, a lot of people can complain of a bit of a myalgia. So where the CPK is normal. And like, sorry, I told a lot of, but it's no, infrequently people can talk about myalgia. So that is the prevalence, we say it's 1 to 5. But then the observational studies report bit more than this. This is the randomized trials frequencies. But then the next muscle-related symptom is myositis, where you find the CPK is also raised above the upper limit of normal. That is very rare. And the most dreadful situation is rhabdomyolysis, where you find CPK rise more than 10 times with renal injury. That is even rare. Then if we talk about the liver effects, statin-related liver effects, so ALT rise more than 3 times normal is again not commonly seen. It's infrequent. Usually it's due to something else. So the prevalence is about 0.5 to 2%. Liver failure is exceedingly rare with statins. So statins are remarkably safe in liver disease, and therefore we should not withhold statins unless there is a very significant reason for not giving statin thinking of liver. And statin-associated onset of diabetes mellitus, yes, it is reported. So it is related to the dose and the duration of statin. But the take-home message is the benefit of statin is more than the risk you get with new development of diabetes. So actually number needed to harm. So to get 1 case of diabetes is like you have to treat 255 people for 4 years to get 1 case. And there is an increased risk of hemorrhagic strokes because total cholesterol is negatively associated with hemorrhagic strokes in observational studies. But again, there is no direct randomized control evidence. What's the effect on kidney? So there is no clear evidence of statin, the effect of kidney injury by statin, but observational studies have observed that there is increased proteinuria with a rosuvastatin dose of 80 milligrams. But it is infrequent with the doses that we use. We never give atorvastatin 80 milligrams, so we need not worry about it a lot. Sorry, rosuvastatin 80 milligrams. Then about drug interactions, yes, we have seen and we have to expect drug interactions because except rosuvastatin and pitavastatin, all other statins are metabolized by the liver cytochrome P450 system. Especially if you give statin with gemfibrozil, there is an increased risk of myopathy. But actually gemfibrozil is not in the use now. There is very minimal risk with fibrate and fenofibrate. So we are a bit scared to give the combination statin and fenofibrate, but actually that myositis risk was observed with gemfibrozil, but not with fenofibrate. It's not very frequent. Then there is a talk about whether it reduces memory, whether it can cause cancer, whether it can reduce the testosterone level, but there is no clear evidence for these. Non-statin lipid-lowering drugs, I'm going to just give you the name. So ezetimibe is the drug that we are talking, the second-line drug, and it has it reduces cholesterol absorption in the intestine, and it has very rare side effects. Fibrates, we know it can cause myopathy. And then we need not talk about the PCSK9 inhibitors because it's not freely available. I just wanted to highlight about omega-3 fatty acid because this is very much widely being used in our country. So according to evidence, there is no overall effect of omega-3 polyunsaturated fatty acid on the total mortality of patients. But there can be some benefit when you give high dose PUFA, so the polyunsaturated fatty acid, you have to give a high dose, 2 grams BD with a statin to high-risk patients who have a LDL cholesterol, moderate hypertriglyceridemia. So you have to give it with statins and have to give a high dose in high-risk patients. So according to this reduce it trial. But there is no benefit by 1 gram of omega-3 fatty acid that is mostly available in the preparations we have in the country. It can have some side effects. GI side effects is the commonest, and it can increase bleeding tendency because it has an antithrombotic effect, and there is some controversy about whether it can increase prostate cancer. Sorry. Right. So, ladies and gentlemen, in summary, this is what you should do if you find a patient with high cholesterol level. So I will take this into 2 slides and discuss because it's not clearly visible, right? So if you get a patient who has a previous cardiovascular disease, so that's for secondary prevention, we have to start a statin. Or diabetes patient between 40 to 75 years, they should be on a statin. But if they are like the statin dose is different, so if they are at high risk, you give high intensity statin. And then if they are low risk, according to AHA guidelines, you may give moderate intensity statin. CKD patients, if they are not on dialysis, you can start them on statins. And if the patient is above 75 years, you need to have a risk discussion and then decide on starting statin. And the next part, like you do a lipid profile. If the LDL level is more than 190, then there is no argument. The patient should be on a statin. If their LDL level is less than 190, then you go for cardiovascular risk assessment. Depending on the risk, if their risk is more than 20%, you have to start them on a statin. The other 2 groups, you can start them on lifestyle modification. So these are my take-home messages for you. First thing, statin is the drug of choice for cardiovascular disease risk reduction in any type of dyslipidemia. So hypertriglyceridemia, if you want to start something, start a statin. Second thing, so we have to prescribe low-cost, high-intensity statin up to the maximum tolerated dose to achieve the treatment goal. The target is set at controlling LDL cholesterol, and it's important to remember, statins are a safe group of drugs with multiple benefits. Thank you.